Next, we have Dr. Alan Leeb. Alan is a Perth GP with almost 40 years' experience in hospital, rural, and metropolitan general practice. Alan has a special interest in paediatrics and immunisation, specifically adverse event surveillance following immunisation. Alan is a primary care researcher and the founder and director of SmartVax, a software platform for the active AFI surveillance. SmartVax partners with AusVac Safety and CDC-DWA to monitor and ensure the safety of the Australian National Immunisation Program. Thanks, Alan.
Thank you. As many of you will recall, on the 22nd of April 2010, the use of the seasonal influenza vaccine in children was abruptly suspended across Australia following an increase in adverse events. This was particularly relevant to Western Australia, as we had a well-established state-funded childhood immunisation program, which was following 3 infant flu-related deaths in 2018. The impact of this event on immunisation rates and confidence was immediate and brutal. For the past 13 years, the SmartVax team, in partnership with CDCD, have been on a journey innovating and researching adverse event surveillance following immunisation. Today, I would like to take you on that journey and give you some insight into adverse event surveillance methodology and the significance of this work locally and globally. This event came as a huge surprise to us at our medical centre. We were vaccinating kids during the day, and they were presenting to the emergency department at night with pyrexia and seizures. In response, I conducted a telephone survey of all parents of all children who had been immunised in the previous month. What we found really surprised us. More than 100 or 38% of the 337 children vaccinated had had an adverse event. 8 were hospitalised and 3 had had seizures. Almost all of these reactions were to CSL's FluVax. The rest, as they say, is history. But what is noteworthy was a significant 10-day lag from suspicion of an adverse event to suspension of the actual program. It was many weeks before a single brand of vaccine was implicated, and then a further 2 years before the exact cause was determined. Up until 2010, Australia, like the rest of the world, relied on a passive system of adverse event surveillance. This relied solely on health providers and the public recognising and reporting suspected reactions to state or federal health authorities. Clearly, the events of 2010 altered this view. I began exploring opportunities to develop and implement a crude adverse event surveillance system from my desk. SmartVax began as a very simple spreadsheet linked to an SMS provider, directly messaging those vaccinated and asking if they had experienced any adverse event to that vaccination. In 2011, I partnered with Ian Peters, a software developer, and together with Paul Effler and Annette Reagan from the CDCD team, we developed the SmartVax platform. We sent our first automated SMS from the Illawarra Medical Centre on the 11th of November 2011. The response from patients and parents and doctors was overwhelming, and there was really appreciation and concern, and we were highly engaged. We decided to expand our network, switching on our first additional network site in August 2014. Rapid expansion took place, and by 2018, we were heading towards 300 sites. In 2014, fueled by the fallout from the 2010 FluVax saga, the National Centre for Immunisation Research facilitated a meeting of the minds in Sydney, and AusVac Safety was born. AusVac Safety is a world-leading national vaccine safety system. It's led by the NCIRS in Sydney, funded by the Australian Government of Healthcare and Ageing. SmartVax partnered with AusVac Safety in 2015. Our first task was to ensure the safety of flu vaccines in kids and instill some confidence in the paediatric vaccination program. Over the next 5 years, AusVac Safety monitored new vaccines introduced to the NIP, such as Zostavax, Bexsero, and Gardasil, as well as multiple changes to the immunisation schedule. Australia was the first in the world to implement an active SMS-based platform and has become a leader in safety data. By the time COVID arrived and vaccine development was underway, we had developed the methodology for safety surveillance of a novel pandemic vaccine, as well as a comprehensive network of sites and a clear process for transmission and analysis of this data. In 2020, the world governments raced to find a vaccine as countermeasure for COVID, and what really surprised us was the diversity of novel vaccines and the pace at which this vaccine development took place. In developing a COVID-specific surveillance platform, we were faced with numerous challenges. Firstly, COVID vaccine would be significantly different to any other vaccine before it. There were multiple vaccine candidates. They were using novel vaccine technology, which had never been tested, and emergency use authorization, which acknowledged the limited testing. We knew that post-marketing surveillance was going to be even more important in this case. Whilst we benefited from the learnings of the past 10 years, we needed to develop a completely new platform for COVID vaccines and set about developing SmartVac version 2. A new COVID-specific survey was developed. We were now able to collect demographic, targeted adverse event data, medical history, management, and the impact on work and safety. With finalization of the specifications in December 2020, we only had a brief 3-month development window with the first vaccine scheduled to be delivered in February 2021. Our team rose to the challenge, working days and nights over the festive season. With COVID, we were working to a scale we had never previously encountered and had limited time to test or scale our system. We really did not know how the platform would perform under load or what the hidden bottlenecks or problems would be. Over a period of a few weeks, we onboarded an additional 170 GP sites, making a total of 460 GP sites across the country, 140 pharmacy sites, as well as a number of dedicated state-run mass COVID vaccination clinics. Our network had expanded to a total of 629 sites by that time. The logistical challenges our platform faced were immense, and a number of novel solutions were found. This is a graph of the number of COVID SMS messages sent per month. We went exponentially from a historical baseline of around only 10,000 messages per month before COVID to a peak of 1.3 million messages during the month of August 2021. We identified and resolved many new bottlenecks along the way, including the fact that our SMS provider had a daily limit of 50,000, which we were unaware of at the time we reached this limit. Also, SMS messages could only be sent during social hours, which further limited our ability to get messages out. The SMS costs were significant. We spent over $71,000 on SMSs in the month of August 21 alone, and we've spent a total of $1 million on SMSs to date. This is just a graph of the annual number of SMSs from 2015 to 2023, and the peak is a staggering 6.5 million SMS messages, which we sent in 2021. This is the typical AEFI surveillance cycle, and it's really important to ask, why is this data important? Where does this data come from? What do we do with this data? And finally, how and to whom do we disseminate and communicate this data? Australia is a global leader in vaccine safety surveillance, and the AusVac safety data has made important contributions to vaccine safety in Australia and internationally. As early as August 2021, AusVac Safety reported in the MJA the short-term safety of the COVID vaccines. These data sources were used and relied upon by the TGA, ATAGI, Department of Health and Ageing, and the public health units continually during the immunisation campaign. A Canadian group analysed active surveillance across the world and published in July 2022 in Vaccine that Australia produces the most research on this topic and that SmartVac was the most studied digital system. We also have it on good authority that the USA VARS system used across the USA was modeled on the SmartVax platform. It's now important just to consider the various types of surveillance. Vaccine surveillance systems may either be passive or active. Passive surveillance still remains the most common route of reporting, and about 2/3 of all data reaches via the passive system. The TGA, like other regulatory agencies around the world, monitors adverse events via a national spontaneous surveillance system where reports are initiated by anyone, including consumers, parents, or health professionals, and these reports can be made online or on paper. Considering the active surveillance system, there are three branches to this. Firstly, participant-centered active surveillance, such as SmartVax and VaxTracker, feeding into OzVac Safety. Secondly, enhanced surveillance via the AFICAN network, which is a network of 55 hospital-based services, all reporting adverse events. And thirdly, and most importantly, data linkage. This links various data sets, such as the AIR vaccination data, to emergency department data, hospitalization, and death databases for identification of potential adverse events. As an illustration of the importance of this data linkage, I would like to just show you some snippets from the WAV's safety report from 2021. This is just a table of the data linkage data. And if we look down this list, most of these conditions would not have been picked up by active participant-centered vaccination surveillance. And considering that our surveillance is only usually on day 3, although with COVID we went day 3, day 8, and day 42. This linked data varies from national active data, filling an important gap in our data strength data. By the 1st of October 2023, Australia had administered almost 69 million vaccines with an adverse event reporting rate of 2 per 1,000 doses. It is critical that this data be shared efficiently and effectively at all levels to improve knowledge and maintain the confidence in our vaccine programs. Firstly, internally, this is internally facing data, which is shared, and this includes detailed reports produced by OzVac Safety and provided to TGA, ATAGI, DOHAC, and relevant public health units. These are very high-level reports, usually over 20 pages long, with highly detailed data and incorporated statistical analyses. On the public side, vaccine safety data has been public-facing on the OzVac Safety website since the beginning of the immunization campaign. This is well curated and well worth a closer look. Safety data is available for all vaccines. This is COVID, influenza, and the whole NRP schedule. This is a screenshot of the public-facing data on the AVS website, initially updated weekly and currently monthly. To illustrate the utility and richness of this data, I'm just going to show you a few slides of COVID-specific vaccine adverse event data. The reactivity of the COVID vaccines is magnitudes greater than any other routine vaccine in use. For Pfizer, 37% of dose 1 recipients reported an adverse reaction, 53% of dose 2, and a whopping 47% following dose 3 reported an adverse reaction. The most common reactions, as expected, were local reactions, fatigue, and headache. Medical attendants, that is seeking medical care from an emergency department or GP, is usually an indicator of severity. This was reported at a rate of about 1 in 100 immunized, or 10% for COVID. If we compare this to regular vaccines, 0.3% in flu, and that equates to about 3 in 10,000. What was the impact of COVID on routine activity? 8% of dose 1 recipients reported missing work. This increased to 21% of dose 2, and 15% of dose 3 recipients missed work, with a majority of 1 day. To further illustrate the significance of the reactivity of all COVID vaccines, I just want to show you some further data from the WAV's report of 2021. The arrow indicates the reactivity rate from the start of the immunisation program in March 2021 compared with the baseline of the previous 4 years. Over a number of years, the number of adverse events reported for non-COVID vaccines remained consistent at a baseline of about 200, which is a ratio of 11 per 100,000 doses. At the start of COVID vaccination program, there were over 10,000 COVID vaccine reports, and this represents a 2,000% increase in the reports from 11% per 100,000 to 264 per 100,000 doses. So where to from here? In keeping with the end of the pandemic and rationalization of the COVID vaccine program, SmartVax version 3 has now evolved to a single platform for all vaccines, inclusive of NRP, COVID, and travel vaccines. A single SMS is sent to all vaccinees with a survey link, with automated uploads to SafeVac and OzVac Safety. With the closure of community and hospital immunisation clinics and the rationalisation of COVID-only GP sites, we've consolidated our network to 398 sites, and currently, via GP sites, SmartVax covers about 22% of the West Australian population. In December 2022, OzVac Safety was awarded the prestigious Data Innovation Award at the 19th Annual Medical Research Awards. Our world-leading platform continues to contribute significantly to local and international vaccine safety, and we look forward to further integration and growth in the ever-evolving vaccination landscape. Thank you.
Are there any questions for Alan?
Hi, Alan. Great presentation, thank you. Just a comment to say, when you talk about the AFI report rate increasing significantly or by 200%, it's also a fair comment to say that because of the increased role of active surveillance there, the more people that you ask, the more AFI reports you're going to get, which is why the AFI report rate goes up. So it's not necessarily a fair comparison to historical AFI report rates, because if you ask more, you're going to get more.
You're going to get more, yeah. But I mean, it just illustrates the reactivity of that vaccine, of all the vaccines, really.
Yeah.
They are significantly higher than any other vaccine we've encountered.
That is a fair point as well.
Yeah.
Yeah. Because I'll be speaking about that a bit later too. Thanks.
I think we forget how reactive that vaccine is.
Thank you for that great presentation. Sammy and I have just had an article accepted, which we will send to you, about public attitudes towards vaccine safety surveillance systems. So in the process of doing that work, I learned quite a bit about surveillance. And one of the things we learned was that you don't need to ask everybody. It's okay to just ask a certain percentage of the population that receives something. Now, your slide just showed we're asking about 20% of, or covering 20% of Western Australia, less of other places. So I was just curious about your goals. How much coverage do you want/need, knowing that statistically you don't need to be asking every single person who receives a vaccine?
Yeah, we've currently limited our current program. We have pruned it. So this is obviously nationally. We started in Western Australia, so that's obviously our largest coverage. And we've got quite good geographical coverage. So we've really made a conscious effort of getting out into all the regions as well. So we probably won't extend it much from the 22%. But you're quite correct. You know, more data just gives you a tighter confidence interval. It doesn't really help you. The issue with COVID was we really didn't know where we were going to go with it. And the amount of data we had was just huge. All right. The health department. we very quickly distanced ourselves from that chance.
Okay, thank you, Alan.